everyone. Good evening. Thank you very much for joining us this evening on our Malaysian Oncologist Tumour board. So today we will be discussing regarding hepatocellular carcinoma as the tumor site. So we are very honored to have Prof. Stephen Chan to join us all the way from Hong Kong today to be with us to share on his knowledge in the management of HCC. Besides himself, we also have group of panelists joining us today for this session. So let me briefly introduce them, each of them one by one. So firstly, we have Dr. Najatul, we have Dr. Zul, as well as Dr. Faizal joining us as a panelist for today's Tumour board meeting. But I know that many of you, probably especially those who are interested in HCC, probably Prof. Stephen Chan is no stranger to you. But allow me to spend 1 or 2 minutes to actually give a brief introduction of Prof. Stephen Chan. So Professor Stephen Chan is actually a clinical professor at the Department of Clinical Oncology of the Chinese University of Hong Kong. And his main interest of research is clinical and translational studies on hepatobiliary, pancreatic, as well as neuroendocrine cancers. Professor Chan has published over 140 papers in peer-reviewed journals, and internationally, he's also serving as an associate editor for the Journal of Hepatology and chair the educational committees for the International Liver Cancer Association, ILCA. And he's also serving history of serving as the track chair for GI tumors in the ESMO as well. So I think without further ado, right, I will pass the floor to Prof. Stephen Chan to share with us his knowledge on when and when not to taste. And then subsequently, it will be followed by 2 case discussion. And the format for today's meeting will be, at the end of each case discussion, we will be having some discussion based on that case rather than presenting both the cases and then have the discussion towards the end. So without further ado, I'll pass the floor to Prof. Stephen.
So thank you, Jikan, and thank you all of my Malaysian friends. It's again my pleasure to come virtually. Hopefully one day I could come physically to see you all and discuss with all the hot topics. So let me share my screen first. Okay. Okay, can you see my slide? Okay, perfect.
Yes, you can see.
Yeah, so the topic I was given today is about the changing role of the TEC in HCC, which I think is a timely topic. So in the next 15 minutes, I will walk you through the following areas. I will give you, firstly, very brief background about how intermediate stage HCC come up as a specific disease group. And then second topic, I will talk about the optimal candidate for the TACE. And the third part, I will talk about very briefly, how do we define the TAC refractoriness, which the concepts have been changing over the past few years. And finally, I will talk about the role of systemic therapy in the intermediate stage HCC. Let me just bring you back to more than 20 years ago in 2000. At that time, about the treatment of liver cancer, we have surgery, radiofrequency ablation. Unfortunately, we still do not have TKI or immunotherapy. At that time, I'm still giving doxorubicin or PF to my patients, which is a cytotoxic chemotherapy. So about the transarterial chemoembolization at that time, it was already performed by multiple groups, but actually the exact role was not yet clear back to the years of 2000. And then in 2002, we have one RCT from the Barcelona group. And at the same time, we also have another RCT, which also from Hong Kong group, showing that the TACE is better than supportive care in certain group of patients. And then when you look at the console diagram of one of these trials by the BCLC group, you can see they actually screened 903 patients. And then they excluded 791 patients, resulting in only 112 patients randomized to the arterial embolization or chemoembolization or the control arm. And then when you try to look at the details of the exclusion criteria, you can see, first of all, they excluded those patients with very early tumors, which should be considered for radical therapies like the surgery or the ablation. And then they also excluded a group of patients which overall belong to more the Milan's criteria that they should be considered for the liver transplant, and their evidence of abnormal bilirubin or portal hypertension. And they have excluded those patients with very poor performance status 3 or more, or patient we're still using occluded stage at that time, basically the patient with very bad liver function and very poor prognosis. So what is the implication? The implication is within this restricted population of 112 patients, then the TAC is shown survival benefit. So actually, traditionally, the TAC candidate are the population derived by exclusion, not by a selection of a specific group that patient that they benefit from the treatment either biologically or medically. So this is why when the BCLC group, when they proposed the conventional treatment algorithm, you can see they basically, for early stage, they subject them to surgery, transplant, or the ablation. And for those patients with advanced tumor and at terminal stage, they're either sorafenib or best supportive care. So this group patient actually very narrow, but there is more by exclusion. So what is the implication? The implication is that the BCLC intermediate stage actually is a less well-defined subgroup of HCC, which tend to have some survival benefit from TAC when compared to best supportive care. Remember, it's compared to best supportive care, not to the current era of like systemic therapy or radiotherapy or Y90. And not surprisingly, by exclusion, this group patient actually is a quite highly heterogeneous population. You can end up like large HCC or patient with multifocal HCC but small sized. And you can have a patient like 1 lesion up to 10 or 20 lesions. So you can imagine this is actually a very heterogeneous subgroup of populations. Then the second part, I talk about what are the optimal candidates for the TACE. I think one conclusion we observe from different clinical trials is that size really matters. For example, on your left-hand side is the BCLC paper. On the right-hand side is the Hong Kong paper. Both trials have shown the benefit of the TACE. But then when you look at more details, the left-hand side, they recruited patients with a median size of around 5 centimeters. While when you look at the Hong Kong paper, we do recruit some patients with big tumors. But you can see for those patients with big tumors, the survival difference not statistically different, significant different. And you can see the difference actually are quite minimal. And the patient even treated TACE when they have big tumors is not very long in terms of the overall survival. The benefits mainly seen in those patients with a smaller size of tumor. So I think one selection criteria is size. And I think this is also compatible with our experience. When you encounter a big HCC, 7 to 10 centimeters, even you after 2 or 3 cycles, you know this patient is not going to have a complete or very good response in terms of the lipid thing. Another point is actually we also consider other factors apart from the tumor number or tumor size, which sometimes we call it beyond Milan's or within up to 7 criteria. We know there are some other prognostic factors such as performance status or this Child-Pugh score or alpha fetoprotein, or even some of the other parameters like the CRP, albumin level. Of course, sometimes we also, because we know in the real world, we also give the TAC to patients with more branch or portal vein thrombosis. Strictly speaking, these are more BCLC stage C, but these may also be considered in some of the TAC population. But based on these prognostication system, we have come up with different names like BCLC subclassification, HHP score by the UK group, or state score by more the European group. But the key point is, we know that the tumor burden matters. Apart from the tumor size, maybe the tumor number also matters. And sometimes we put a term like within up to 7. So when you submit the largest tumor size and the tumor number, if it's below 7, we know that these patients tend to derive more benefit from the TACE. Another is the sorry about the table, should be preserved hepatic function. The better the hepatic function the patient, they will derive more benefit from the TACE. This is just, again, a graphical illustration of the Kinkey's criteria. I think the main concept is if the patient have very big tumor, they will not benefit even with a selective TCE. Or for patient with a biloop HCC, we know that when you give multiple cycles of non-selective TCE, it's going to lead to hepatic damage, which may also be very good in terms of the survival of the patient. And also we know that with more and more TCE, especially in the beyond up to 7, you are bound to see a patient with a deranged liver function, which nowadays is a concern. Because the worse the LB score, we know that they have worse prognosis when they're receiving systemic therapy. And also when the patient has poor liver function or suboptimal liver function, they are not able to receive multiple lines of systemic therapy, which can be a concern in the today's standard practices. And this is why when you look at the revised BCLC criteria, they no longer understand the problem with the intermediate stage. This is why they appreciate the fact that for those patients with a certain limit size or lower FP, they may be considered transplant. They still have benefit. While for those patients with a diffuse, infiltrative, extensive biloop liver involvement, basically it's the concept tumor burden or plus or minus non-selective TCE, they may be better treated with systemic therapy. So actually the role of TCE nowadays is more confined to those patients really with very well-defined nodules, preserved portal flow, and you can also give selective TCE. So we should give up the concept of so-called palliative TCE now. When we give TCE, we aim for more complete, smaller disease burden with complete more response to the patient, while the palliative role may be left for more room for the systemic therapy. Then I use one slide to talk about the refractoriness. I would say this concept, when we're in the tumor board, how do we say, oh, this patient should not be given further TCE? This is a very dynamic concept with multiple factors taken into consideration. Conventionally, we'll consider if you give 2 cycles of TCE and you do the CT scan or MRI scan, and you didn't see very good response, either not much lipido stain or tumor become larger or there's some new nodules. I think nowadays it's quite a consensus that this patient will not be a good candidate for further TCE, and they should be switched to other treatment, usually systemic therapy, based on the disease burden and hepatic function. And also, we know that tumor burden, if sometimes the patient already been moved to the BCLC stage C or extrahepatic spread or vascular invasion, I think this is also a consensus that the patient should be stopped for the TACE. Also, we know that if the patient have some sustained child B function or some absolute contraindication to the TACE like the portal hypertension or present ascites, they should also be considered not suitable for further TACE. And some people also come up different art score, but I think the key point is, apart from looking at efficacy, we also look for any evidence of hepatic damage from the TCE. If there's a more cumulative evidence that the patient, let's say, have lower albumin now, we should consider stopping the TCE and change to our systemic therapy, because you know that when you give further TCE, you will further damage hepatic reserve. The patient may not have a chance to receive the effective systemic therapy. And also, I think now we should give up the concept of fixed schedule. I think in the old days, when I discuss with our surgeons or radiologists, sometimes they'll say, oh, we just give like chemo every 2 to 3 months, TACE, TACE, TACE. But we know this concept should be obsolete because this will cause liver damage. We should assess the patient's liver function and the tumor response after 1 or 2 cycles. Then we should assess the patient instead of keeping TACE the patient. So therefore, I would not say there's a fixed rule, this patient should be stopped. But you can see based on this consideration and depends on your accessibility to systemic therapy, I would say we tend to give less and less TCE, especially for patients with a higher disease burden, unless the patient have really good response. But if they have good response, we just give 2 or 3 cycles, stop it. We give up the concept of keeping so-called maintenance or consolidative TACE. Then finally, I talk about the concept of TC versus systemic therapy. As I mentioned, the TC is established in the era when we don't have other effective systemic. So they are compared to the best supportive care. And this is a concept, a proof of concept trial, actually published few years ago already. It's led by Professor Kudo, but also I have involved in the design of the study. In summary, is we recruit the patient with good liver function to start with, but they have a beyond up to 7. So this patient are still having an intermediate stage XCC. So they are randomized. They are actually receiving prospective cohort and receiving the TACE and also the lenvatinib. And then we try to match the patient with the propensity score matching. And surprisingly, you can see when you compare the patient treated with the prospectively lenvatinib versus with the TACE, actually the patient treated lenvatinib have a much better overall survival and also the PFS. You may be surprised, but actually, when you look at the details, you shouldn't be too surprised because TACE, we know, when you're given selectively to smaller disease burden, they're perfect. They can induce high radiological response with just the 2 cycles of TACE. But for those patients with beyond up to 7, actually, they have biloop disease of big XCC. You need to treat them with a non-selective TACE, and we know this is not good for the patient. In fact, this is also shown by this study. You can see that as move on from baseline, 1 month, 2 months, 3 months at the end of the treatment, and you can see when you look at the LB score, there's a preservation of the hepatic function effect by the lenvatinib. While you can see for the TACE, actually they have a worse deteriorating hepatic function in terms of the LB score. So this again a proof of concept that for patients with high disease burden, for example, beyond up to 7, they should be considered systemic therapy. Of course, nowadays you can argue maybe when we give atezolizumab or some of other immunotherapy regimen, this benefit will be even higher, which I agree. We are waiting for some clinical trial result now, so hopefully we can have see some more data with the immunotherapy. And this is why I think back to 2020, the Apple have been issued a guidance or concept consensus on changing paradigm of the treatment of intermediate stage XCC by the Apple. I will not go into too much detail, but the concept is, in the old days, we just give TC to all intermediate stage XCC, and then we leave when the patient develop refractoriness or other contraindication, then we put the patient on systemic therapy. But we recognize a proportion of patients who are defined as more like TC unsuitable, which means that they are technically suitable for TACE, but we know they are not suitable for TACE in terms of the biology. These are the patients like LB grade 2. If you treat them with TACE, they have high chance of going into liver failure, and also beyond up to 7 for the reason that I mentioned. And also for poorly differentiated histology, you have biopsy the patient. We know they're also poorly responding to the TACE. Usually radiologically, these are the group patients with more infiltrated diffuse borders. We know these less defined XCC, they are also not suitable candidate for the TACE. And we propose this group patient, they should be treated with systemic therapy first. And we can reserve the local regional therapy like TACE if they have a demonstrated good response, a patient with very good response, but then with oligoprogression, then this patient, they go back to receive the local regional therapy. This will be a more practical approach for the patient, and also will preserve the hepatic function. And of course, another area we can discuss in the tumor board is whether we can add systemic therapy, not replace, add the systemic therapy on top of the TACE. And this actually have been addressed by the IMMray-1 study. Basically, we recruit patients treatment naive, mainly the BCLC-B plus some minus patient with VP1, VP2, but they excluded patient with VP3 or VP4. And then they randomized to TACE plus Durva, followed by Durva plus placebo, or TACE plus Durva, followed by Durva plus bevacizumab afterwards, or the TACE plus placebo, followed by placebos. They maximally allow 4 cycles of TACE within 6 months of time. The good news is actually you can read there's a press release. This study is positive. They prolong the progression-free survival significantly with clinical meaning, and so this study will be presented in ASCO GI. So we look forward to seeing this data, which will potentially be practice-changing. This is the first and the largest clinical trial on the TACE plus the immunotherapy, RCT. So, ladies and gentlemen, I will conclude my talk. I would say nowadays the line between the intermediate and advanced HCC is less clear-cut, which is not surprising because we have a recent development of systemic therapy, and also by default, the intermediate stage HCC, they are more by exclusion, rather a specific entity defined by the biology or disease burden. And also, actually, this is practiced in our hospital, and I think it's increasingly practiced by different MDT, is that if a patient comes to us with a high burden intermediate stage, by loop diffuse HCC, we consider they should be treated with upfront systemic, rather than strictly following the OBCLC with the TACE. And this also could help preserve the hepatic function. But of course, we wait for more studies, which I think will change how do we view this intermediate stage HCC and also the role of the TACE. Maybe in the future, TACE is no longer the standard for this group patient. We should treat like TACE plus systemic therapy followed up by systemic therapy. And this make even the intermediate stage and the advanced HCC less distinguishable in the future. So thank you very much for your time. I look forward to discussing the further cases and addressing any questions or discussion with all of you. Thank you very much.
All right, thank you very much, Prof. Steven, for your wonderful sharing. So I think we will keep the question a little later because up next we will be sharing a case. So question with regards to TACE, local therapy versus systemic therapy will be addressed after the first case sharing. So without further ado, let me just share my screen so that we can want to have the first case presentation. Right? Can you guys see my screen? Okay. So just to cut it simple, so I have this patient, Madam C, a 77-year-old lady with underlying diabetes and hypertension. It's a non-Hep B, Hep C with no family history of cancer. And she was diagnosed actually with advanced HCC, still with good liver function and relatively good performance status of 1. So in January 2022, so it shows that there is actually a huge liver lesions, more than 7 centimeters with some subcapsular nodules measuring up to even close to 6 centimeters. And at the same time, there are some nodes as well being present. And of course, patient also noted to have one small right lower lung nodule of 1 centimeter in size. So looking at this patient, if let's say the patient were to present to you in the clinic today, right? So what would you offer the patients? So I think based on the general knowledge that we have, basically this patient probably is not a suitable candidate for local therapy for a few reasons. Number one is because of the huge tumor burden in the liver, as well as the potential extrahepatic spread. Hence, we think that this patient probably would better off with systemic therapy. Unfortunately, patient actually was given TACE, and then the repeat scan 1 month after that showed that actually there is some response in the primary tumor, but actually the nodes was still stable because it was not being taken care of by the case itself. And actually there's a marginal increase in size of the lung nodule from 1 centimeter to 1.2 centimeter, right? As you can see from the scan here. And then patient goes on to receive the second TACE the following month. And again, the scan after that showed that actually there is lesser enhancement, but the lung nodules and the periportal nodes has been stable. And then subsequently, because of the still presence of residual disease, patient were offered the third TACE the following month. And again, you know, the scan showed that there's still residual disease, even though there are some form of response, but the lung nodules and the nodes were still stable. So patient was given a break of 3 months subsequently, and with a repeat scan in August. And the scan now showed that the residual liver lesion has increased compared to the last scan. And the lung nodules has grown from about 1.2 centimeter to double the size now to about 2.6 centimeters. So as you can see here in the scan showing the larger lung nodule. So as usual, we will be asking, you know, what will be the next? Since that the patient did not have a complete response in the liver lesions, there are presence of nodes, and now that the lung nodules has actually progressed, of course, we always felt like, you know, it's better for the patient to actually goes on to receive the systemic therapy, provided that the patient performance status is still good and the liver function is still being preserved. However, patient was given the 4th case instead in October last year, and a repeat scan about a month plus subsequently showed that there's actually no change in the liver lesion after the case. In fact, there's actually now tumor thrombus, and the lung nodules has actually increased further from about 2 over centimeters to about 3.3 centimeters. So in summary, this patient actually came and visited me in December after the last 4th case and the scan showing that, you know, the lesions is now not responding to case and the lung nodules has actually increased in size. Patient came and then actually maintained her liver function and her performance status. And then subsequently, I offered her, after discussing with the family members on the options of treatment, family decided to go on to receive lenvatinib, and the patient was given 10 milligram at the end of December last year. She tolerated it quite well, without much of a hand-foot syndrome. Blood pressure was mainly well controlled, and she actually clinically improved after the lenvatinib. And the first interim scan done 3 months subsequently showed that the disease has been stable. However, subsequently, a few months down the road, she beginning to feel unwell and things deteriorated rapidly, where her liver function became deranged, and the scan that was done showed that the disease has now progressed both in the liver as well as in the lung as well at the same time. And subsequently, patient passed away in end of June this year. So thank you. So that's my short case sharing. So basically what I wanted to illustrate in the case is that I think I'm not sure how many of the participants who came today actually seen similar cases, but to me, I think this is not a very unfamiliar presentation to our clinic, because I think traditionally over here in Malaysia is that many of these patients are presented to the surgeons, where they either go for resection or local therapy with the interventional radiologist before they think that it's not working anymore, and then subsequently refer to the oncologist for systemic therapy. But I mean, the practice has been molded such a way is because, like Prof. Stephen mentioned previously, is that we do not have very good systemic therapy previously. And even nowadays, with so many systemic therapy being approved in the treatment of HCC, but unfortunately, in the public sectors, which is catering to majority of our HCC patients, still do not have most of this drug. And in fact, I think lenvatinib is the only systemic therapy being approved and available in the public hospital at the moment. Of course, I think the colleagues in the public sector has done very well, because I think in certain patients where they felt like, you know, patient will really benefit from the oncology combination, they will actually request for the drugs for those particular patients rather than just giving them, you know, the lenvatinib or the chemotherapy. So I think with that, we are happy to take questions, especially with regards to Prof. Stephen's presentation, as well as the case that was shared, before we move on to the second case later on. So is there any questions so far from the audience? No questions?
Jikan, can I ask you a question?
Yes.
About the patient that you have presented, can I know, can you share with us, after TACE, when you look at the imaging, go back, of course, this is more, I know you will refer after the TACE.
Yep.
You see how strongly is the lipado stain? I know you have mentioned less enhancement, maybe some hypovascularity, necrosis.
Yep.
For such a big tumor, after 2 or 3 cycles of TACE, how do you see the lipado stain? I believe it's more like patchy instead of the whole tumor being stained.
Yeah, so I think it's generally patchy, and in fact, even the radiologists find it a bit difficult for them sometimes, you know, to report on the finding, because it's basically not like the other tumors that we normally treat, where the tumor will shrink, you know, then you can actually measure the enhancement and all. So like you rightly mentioned, I think generally is that the enhancement is patchy, you know, and then especially with the huge liver lesion, sometimes it's very difficult for them to quantify in terms of the size of the tumor. So if you were to see that, I actually did not really, you know, present on the size of the tumor anymore, because those are not what is being reported, because the radiologists find it difficult for them to do that. So it's basically just eyeballing the enhancement, and then after that, basically just giving a rough estimation in terms of the percentage of the enhancement that has disappeared or have become necrotic, compared to the previous scan.
Yeah, I know Dr. Masura had a question. I just get a quick comment. One challenge to these type of the big tumor is sometimes they have a lot of blood supply, not from the common hepatic artery. If you ask the radiologist, sometimes they derive the blood because it's so big. Usually, if the tumor is at the dome, they will derive supply from the diaphragmatic artery, the phrenic artery. While more, if they're close to the bowel, actually they derive the supply from the mesenteric artery. So basically, it's difficult or impossible for such a big tumor. You can just by catheterizing the common hepatic artery to expect some very magical response. This is just my comment. Yeah, thank you.
Yeah, I think completely agree. I don't think to begin with, this patient is a candidate for the TACE. So I think I saw Dr. Masura raising her hand. So Dr. Mas, is there any question?
Yeah, I actually want to ask the opinion of Dr. Stephen as well as the other panelists with regards to, in such a situation, if let's say the patient is doing well, what is the imaging modality that you prefer in order for you to evaluate the response? I mean, with the lipodol and all. Is it CT scan or is it MRI? Or how? That's my first question.
Yeah, also. In Hong Kong, we prefer MRI. To avoid you can avoid artifact of lipido. Another point is try to avoid very early scan. Sometimes we do it like 4 to 6 weeks earliest afterwards. So if you do it like 1 or 2 weeks after TACE, it's a very difficult to see the effect. This is our experience. But of course, MRI can be challenging in some center because of the resources. This is our experience.
Okay, so if let's say after we call TACE TACE here, so after TACE, if let's say the patient's liver enzymes goes up and are there anything that we can give to the patients? I know there are some liver drugs that I can't remember the name now, but people give to patients to improve on their liver function. But do you also use those drugs? Because patients get jumpy when they have raised enzymes.
I can leave to our Malaysian colleagues. If we have a sky-high liver enzyme, usually the data, I think there's a lot of studies many years ago, actually showing that it's more associated liver injury to the non-tumorous part of liver. My experience, there are not many things we can do. Apart from some supportive medications like fever, Panadol, or some antibiotics, usually it takes some time. You are right. Sometimes it takes up to 6 weeks, 7, 8 weeks if it's really severe injury. And some actually have never returned to normal. I've seen some cases like this, if they're bad livers to start with. But I'm happy to hear the experience from our Malaysian colleagues here.
Yeah. So I personally don't start the patient on any of the liver tonic. I think some of the gastro or hepatologists do. I think generally when the patient actually post-TACE or TACE, there are occasionally where the patient will have a transient raise in the liver function, especially the enzyme. But sometimes, like what Prof. Stephen said, that the liver function doesn't come down. So generally, I think when the patient just had a recent TACE coming to me for consideration of systemic therapy, what I will do is that I will continue to monitor the liver function to see how's the trend like. Of course, if let's say there are signs that it's actually improving, then probably I will wait a bit longer before actually initiate the patient on systemic therapy. But there are times when the liver function doesn't improve further, there's no sign of it actually coming down even after like 2 weeks or 4 weeks. Then I think taking a clinical decision based on the patient, probably you might need to initiate systemic therapy, provided I think the liver function is still within the safety limit that we actually can provide the patient with the systemic therapy. But I'm happy to hear the other panelists to share whether, do they start anything on the patient, but personally, I don't.
Maybe I can just also share in Sabah, they are followed by the gastro as well as the hepatobiliary team. For the patients that I have seen, I think they do not use any liver tonic routinely. They just give some time for the liver enzymes to recover. With regards to the imaging, I think resources is the main issue. So they use CT for assessment after TACE rather than MRI.
Okay, thank you, Raja. So I think Jensen did ask a question here, is that is there any criteria?
That's yeah. Go on.
Yeah, so Jensen did ask about, is there any criteria that can be used to assess treatment response post-case, i.e. like any radiology scoring criteria and all. So I think in a way, that question is partially answered by Prof. Stephen earlier with regard to the reassessment. But I personally do not know any specific criteria that the radiologists use. Anything from the panelists? If let's say there's none, then I think due to time constraint, we'll probably move on to the second case presentation by Dr. Zul. Yeah.
Can I just ask Prof. Stephen, in the study that you mentioned just now, done by Dr. Kudo, I think they use a separate criteria, right? They use RESIC-L. Is that practice in your hospital when you assess this one?
No, we usually put it that way. I think RECIST and modified RECIST are more for clinical trial. We try to standardize the language we are using. If in real world, I think most of my radiologists, even in our tumor board, we don't say, oh, this is RECIST SD over. We'll just say, as mentioned by Chikan, it's like there's a reduction in the enhancement. We do use the concept modified RECIST, but we don't strictly calculate the PR SD unless in clinical trials.
Okay, so I think probably we will pass the floor to Dr. Zul to share the subsequent case before following by further discussion. Dr. Zul, please.
Okay, thank you, CK, for the introduction. So I'm going to present, just let me put up my slide. Okay, all right. So I'm going to present a case today. Okay, this gentleman, 71-year-old man, he present his background history of hepatitis B, being treated hypertension and hypercholesterolemia. So January 2023, he presented with 2 weeks history of dyspepsia. Before that, he was quite well, no major symptoms. He was seen by a gastroenterologist in our hospital and did a OGD which showed mild gastritis. And then he had some blood works done, and he noticed that his alpha fetoprotein is 11,000, more than 11,000. And this is his CT scan. You can see that there's a huge mass in the liver, okay? And it's enhanced in the anterior phase with early washout during the late phase. And there's also lung metastasis, which I don't have any picture, okay? So looking at his blood works, we estimate his Child-Pugh score, and he had 6-point Child-Pugh class A. So at this point, we were postulating what type of treatment should we give him. It's still good performance status and, you know, doing quite well. So what do you think? What would we do? Maybe I can ask the panelists what are your thoughts are?
I think like a bit in a way a bit similar to my case earlier. So I think generally looking at the size of the tumors, I don't think the patient is a candidate for local therapy, especially with the extrahepatic aspect of lung metastasis. So I'll offer the patient systemic therapy. In terms of what are the choice of systemic therapy, then of course that will be subject for discussion, because I think for practical reason you have to take into consideration the cost, side effect profiles and things like that. And if let's say the patient were to be given atezolizumab in the first line setting, then I would like to also have OGD at least done for the patient to look for whether is there any esophageal varices.
Excellent. Okay, so due to time constraint, so this is the NCCN guidelines. As what CK said, there's plenty of options, but at the moment the preferred regimen will be either atezolizumab or durvalumab. So for this patient, I have discussed all the treatments that is available, and finally they agreed to start on atezolizumab. Patient did have OGD earlier on, and it only showed mild gastritis without any varices. So he would be a good candidate due to less risk of bleeding. So just to touch a little bit on the atezo-bev, so the IMbrave 150 phase 3 open label trial look at atezo-bev in comparison with sorafenib. So patients were randomized and it started on the medication until loss of benefit or unacceptable toxicity. So as you can see that there is a benefit for, there is the benefit in improvement in median PFS for patients started with atezo-bev in comparison with sorafenib. In terms of OS, the updated data said that the median OS for atezo-bev is 19.2 months in comparison to sorafenib of 13.2 months, again with significant p-value as well. So after starting the atezo-bev, the AFP did drop a lot from 11,000 to around 4,000. This drops again in after around 2 months, and then in April it starts to increase back again. Okay, and at that point the patient also starts to complain of mild chest pain and mild shortness of breath. So I did a scan. At this point, it shows there is a mild increase in the liver size, but now there is extension into the inferior vena cava and also at the right atrium. Patients also develop right pulmonary embolism and right mild pleural effusion. The lung metastasis is stable. So he was referred to the cardiologist, and cardiologist ordered a cardiac MRI. This showed irregular hypointense lesion in IVC extending into the right atrium. There's no enhancement, so this is not a direct extension. And in view of the liver lobe hepatoma, it's most likely a thrombus. And this patient was put on anticoagulant. Patient performance status still quite good, and his Child-Pugh score still remain A. So what would the treatment of choice would be? Maybe some other takers?
Maybe I can try. So she failed atezo-bev. I think data for tremelimumab and durvalumab is in the first line setting, but the other options are reasonable options for the second line. So I think it depends on what you have and how she responded before to IO, whether you would like to switch to an anti-VEGF or multi-kinase inhibitors. It also depends on your familiarity with all the drugs and also the side effects profile. I think sorafenib is not an easy drug, as well as regorafenib. I'm more familiar with Lenva. I think cabozantinib is also a valid option because we do have data for that in second line and also third line setting. So I think all of that are reasonable options.
Prof, what are your thoughts?
You just tell me, maybe I missed it. How many cycles have the patient undergone the atezo-bev?
Patient had 4 cycles of atezo-bev.
First of all, I think this is a clear, to me, it's more PD now. The chance of pseudo progression is quite low after 4 cycles. So I tend to switch the treatment. Another concern, of course, if you're on anticoagulant, even on NOAC, I think BAF is a concern, right? When you give high dose, bleeding is a concern. So this patient's a challenge. I would say TKI is an option, although still associated with some risk of bleeding. Either you use Rigo, Cabo, Lenvatinib, but I think if you want aggressive treatment, this is an option. Whether you continue the immuno or change the backbone immuno, this is we don't have high level evidence at this moment. It really depends on the patient's wish and your feeling. But I think TKI is definitely will be the cornerstone of my management. I would choose Lenvatinib, cheaper. We have more experiences, easy to adjust the dose. Yeah.
Okay, good choice. So again, NCCN guidelines listed few options here for this patient. So after discussion with this patient, I put on the cabozantinib, and main reason would be that this there's a good program by Axios for cabozantinib, and patients already being challenged financially. So for purpose of discussion, I've listed up some of the questions here. So there is no standard second-line treatment post-Atezo and BEV, like what Prof said earlier, and also Naja said that TKI depends on the cost, familiarity, and things like that. In terms of whether I would continue the Atezo BEV or not, I think it's quite clear that, like what Prof said, this is not pseudo progression. The EFP has increased. I don't think re-challenge the patient with another IO also would be of benefit, since it's not a prolonged response initially to Atezo and BEV. So after cabozantinib, patient AFP responded, but unfortunately he developed anorexia, tightness, and his quality of life starts to drop despite multiple dose reduction. So we decided to stop treatment after 3 months, and patient is now on best supportive care. Thank you.
Can I just give a quick remark? Actually, you chose a drug that we have run a clinical trial. Actually, we have reported a phase 2 trial, multi-center study on cabozantinib after mainly Atezo-BEV in parallel immunotherapy. It's the first prospective study. It was presented as ESMO Asia last year. Actually, we have submitted the paper and we got positive. We are revising the manuscript. Hopefully, you can see the paper, which we using cabo. Actually, it's effective. But as I can imagine, this patient is quite frail. And we know cabo can be a concern in those patients more frail, poor, less optimal liver function. But I think you make a good choice. Thank you.
Thanks, Prof.
Thanks, Zul, for the sharing. So I think just to probably to continue with the discussion regarding the systemic therapy, probably I also like to throw the question back to Prof as well. So Prof, how do you, to me, I think based on this particular patient who had Atezo-BEV and the current condition, to me, I think my choice, I will limit it mainly on the TKI. So that will be either lematinib, cabozantinib, or even sorafenib. But personally, due to experience, due to I think the side effect profile, I will limit them down to either lematinib or cabozantinib. Okay, for this particular patient. So like for Prof, is there anything that can help us to guide how do we actually choose the second line if let's say the patient actually had Atezo-BEV in the first line setting? Because in Malaysia, we do not have the strike regimen yet. It's currently not available unless we ask for a special import permit. So I assume that Atezo-BEV is the first line in Malaysia for most of the patients. And then, so how do we actually go about in choosing the second line? Because to me personally, I wouldn't re-challenge a patient with another immunotherapy after failure of one immunotherapy, even though we have data of nivolumab in the second line setting, but that is something that I would not consider at the moment until we have a stronger evidence to support this usage. So yeah, Prof, can you please help to share us, how would you go about it?
Jikan, you raise very good questions. I think now, if you look at all guidelines, ESO, the ESMO, ASCO, I think so, they no longer consider the first line, second line TKI concept. They consider after failure of immunotherapy, mainly Atezo-BEV, all TKI have similar role or stance. So you can either prescribe the level, you make a good choice. Sorafenib is very weak, we know that, and probably is not preferred. If you ask me, although we have some data, I would still prefer lenvatinib because it's better tolerated. The side effects profile is more, predictable. For cabo, sometimes we do see, especially when you give full dose, 60 milligram, we do see patient more problem. I would say cabo is much more potent, but you can be also more toxic. So I tend to give lenvatinib, which we have more experiences. And also cabo, interestingly, I've seen some patients who fail many drugs, even TKI. When they give cabo, we still have some period of progression-free and some response. I think cabo did have some additional MET inhibition, which make them suitable or have some unique role as a third-line agent. Maybe Ipsen doesn't like this concept, but I tend to use lenvatinib first and then cabo. And I will just add one more point. I just given a talk in ESMO. Interestingly, when you look at literature, some people do have run some study to biopsy the patient again after failure of Atezo-BEV. Interestingly, you see around 20% of them will harbor some actionable mutation, especially the TSV1 or TSC2 loss. And some actually have some brachynas, which make them suitable for some target therapy like everolimus or some like olaparib. I'm not saying we should do this, but bear in mind, this is a very underexplored area if you talk about personalized treatment. But I will follow the lenvatinib after more than carbo in the first line. But this is my personal thought. Thank you.
Thank you, Prof. Any other question from the floor? I think we have one question from Audi. So Audi's question is mainly towards Prof. What Audi asking is that, Prof, do you have experience in using hepatic intra-arterial chemo or TACE or basically local therapy in combination with systemic therapy for unresectable HCC? I think besides the data that was presented by you earlier regard to TACE with durvalumab, I think we also do have some data with support of using TKI with TACE like lenvatinib in the launch trial and all. So what's your thoughts on that, Prof?
Yes and no. I would say TCE, if you put it that way, use it in a well-defined, well-selected population. I feel happy to add some systemic therapy. And I'm sure when you see the data of the IMMO, people will no longer talk about TKI. People talk about immunotherapy. This is my feeling. But the problem is, TC sometimes can be used in patients with quite a big tumor, heavy disease burden. And as mentioned by Dr. Masura, some patients can have quite stormy course, fever, abscess, ischemic, loss of appetite for quite a long period of time. And we know when you use targeted therapy or even immuno can be a challenge when they have a high ALT. So what we know now is adding systemic is good for some patients. It can improve the progression-free, it can improve the OS. But whether we should give for all patients with TACE, probably no. We still need to individualize. But how to select? My feeling is that liver function and also the disease burden will play a key role. If they really have extensive disease burden, borderline liver function, I would prefer systemic therapy alone. So how to dissect out this TC plus or TC alone or the systemic alone? This will be a great topic for the next 5 years of time for research.
All right, thanks. I think I completely agree with you. I think, of course, it's multifactorial, but one of the criteria I use to help me to guide in terms of the assessment of the tumor burden will still be within the 7 criteria as one of it. Of course, there are also other factors that we take into considerations. I think we are going to be reaching 6:30 soon. So I think allow me the priority of asking probably the last question to Prof is that I think AZ probably will be filing for the approval for durvalumab as a monotherapy based on the other arms in the Himalaya study. So, Prof, I'd just like to get your view is that, of course, we know that if let's say there's no contraindication, combination will still be the preferred choice because of the overall survival benefit. But when you talk about patients who can't go to have the combination, then how do you choose and where do you see the role of TKI or single agent immunotherapy in the first line setting? So is there any way that you can guide us to, on who you will actually opt for a TKI or who will you opt for a single agent immunotherapy? Because to me, personally, besides response rate, I will personally probably prefer a single agent immunotherapy, mainly because of the chance of probably patient being a long-term responder because of the duration of response, or even a smaller percentage chance that the patient might go into a complete response, which I think TKI is something that TKI will not be able to provide. So I'll be happy to hear your thoughts on this.
Fully agree. Chikan, I can share with you, we have done some internal data, and also I read some real-world data. Interestingly, when you compare the immunotherapy first line, either combination or the single agent, or post-patient treated first line TKI, actually, in the real world, the median overall survival is quite similar. But when you look at the tail, the 2-year overall survival rate, there is much higher in the single agent immunotherapy arm, even single agent immuno. So if you ask my practice, if the patient have no contraindication to immuno, if cost is not an issue, I tend to start immuno first. you will select out a proportion of patients who are winner. And if they have PD, usually you know after 3 or 4 cycles, change to TKI. That's it. To me, it's very simple. And you have a chance of selecting patients with long-term survivor. But obviously, if the patient have contraindication of immuno, I have still seen a lot of patients thyrotoxicosis, graveside disease, autoimmune, or cost is still an issue, then TKI. And they still have a reasonable overall survival, but don't expect long-term survivors. This is my experience so far.
Thanks, Prof. So sorry that I think I missed out a question from another panelist. I think Dr. Azura did ask about, is there a difference in the expected response from immunotherapy if a patient is Hep B or C positive compared to non-viral related HCC?
To me or to the panel?
I think maybe probably to you and to the panel as well. Probably you can chime in first.
Yeah. If you talk about mono, the Nature paper, there's a trend that the long B, long C, they tend to derive less benefit. That's for sure. But when you talk about combination, and also when you have more newer trials, actually there's a meta-analysis by Dr. Meyer published in JHAP. When you recruit more combinational trials and the newer trials, actually the differences are not that huge. And the long B, long C, they still derive benefit. So I think that now the mainstream authorities we tend not to select patients for immuno based on etiology, which is very crude, unless we have more data. So this is, but I can tell you, my experience with those super responders are more happy patients, that's for sure. But whether you should just based on this to select out those patients long B, long C, not for immuno, we don't know yet.
Other panelists? So I think I do agree with Prof. Stephen. I think generally, even the guidelines, any of the international guidelines that's commonly being used, I think none of it actually suggests to choose the first line based on the etiology as one of the reasons. So to me, I think on how to choose the first line, it will still be based on the, I think, side effect profile, whether there's any contraindication to any of the agents, you know, and then of course, cost in the practical for practical reasons as well. Yeah. So I think if let's say we have no more questions, I would like to thank you very much to Prof. Stephen and all the panelists, Dr. Mastura, Dr. Zul, Dr. Faiza, Dr. Najato, for joining us today, right, for this Tumour board. I think we learned a lot from Prof. Stephen. Right? Thank you very much once again for joining us and sharing your knowledge with us on the management of HCC. And thank you very much to the other participants for joining us for this Tumour board. So with that, I will close this event. Thank you very much and have a great evening, everyone. Bye.
Thank you. Thank you
very much.
Thank you, Prof.
Thanks, Prof. Thank you. Thanks, EK.
Nice.
Thanks, Prof.
Thank you.
Thank you all.
Thanks, Najat. Thanks, Faisal.